Hey guys, a very good evening. Hello, Facti YT. Glad you're ready. Hello, Shubh Sangam Kumar. A very good evening. Am I audible? Am I visible? If yes, please let me know and let's start. Okay, there are a few advertisements. Just give me a second. Okay. Hey guys, hope I'm audible and visible. And if things are ready and good to go. So we had a brief introduction of what we are going to do in the critical thinking series. I'm going to just take simple case scenarios, the exact same case scenarios what you will be seeing in your college, in your ward postings, in your hospitals, and the way how to approach it, right? I also want inputs from you. I'll have, you must have started history taking, right? How many of you have started history taking in your college? Medicine, surgery, OG, pediatrics, anything. So what the initial part will be a case discussion. That's all. Like I'll give you a simple history. I want you to tell me what are leading questions you will ask. I'll obviously go to clinical diagnosis. Then only we'll start the pathological part or the investigation part. Like yesterday in the lecture, I said that it is never the image alone. It's never the investigation alone. It's always together, right? Okay, it's always together. So with that, definitely we'll be able to come to a conclusion. Hello, Aya. Right. So let's start. So let's say you are in your OPD and you have a patient, or in your ward, you have a patient that 32-year-old male presents with shortness of breath for 2 weeks, a dry cough, right-sided chest discomfort. Right. Over to you guys. What all questions will you ask? It's a simple patient who came to the OPD with a cough for 2 weeks. It's a dry cough and right-sided chest discomfort. What will you ask? Anything which comes to your mind? Anything which comes to your mind? What are questions you might ask here? Just give me a second. I think the orientation is a little bit bigger. I'll just change it so that we can see the full screen properly. Okay, sorry for that. Please shoot your questions in between. Fine. Okay. Anyone, come on, guys. The discussion has to initiate. For a discussion to happen, I need answers. I am not going to be a professor who's going to penalize you if you say a wrong answer, but I need answers. Without answers, we will not be able to go ahead. Fine. Okay. Age, diet. Facty great. Age is already there, 32-year-old. I am not sure how a diet might help here, right? Course of cough. Okay, so I'll tell you there is a, again, it's given that it's a dry cough, history of any medications. Okay, Siddhi, can you tell me like why do you want a history of medication? It is definitely a past medical history is relevant, but if I have to ask one or two leading questions to this patient, I might not go to the medication history first, right? Because I have few classical findings here. Obviously, the leading question has to start from the patient's finding or a patient history. Perfect. Progression. I have to ask how fast is it? Is it very progressive or is it slowly progressive, right? Perfect. Great. Right. So that's some simple question which I want to ask, right? So the questions you have to ask pertaining to this history. You will have a big case pro forma which you have to do in your ward. But for the case of discussion here, I'm just going to divide the questions which I want to ask. Onset and the progression of breathlessness. It's a slow onset and an insidious onset and a very gradual progression. It's not becoming very fastly progressive or rapid, right? It's a very gradual progression, right? The next question I want you to ask is, was there any history of fever, weight loss or night sweats? Again, question to you guys. Why do I need to ask history of fever, weight loss or night sweats? What I'm leaning towards? Anyone? It's a problem in the heart or lung. I'm not sure exactly because breathlessness, dry cough, maybe both, but more leaning towards lung. What do you think this entails? Dr. Santosh will definitely talk more about what is fever, what all questions to ask, what is weight loss, what is night sweats in his Harrison-based series. If you missed that, just go to the YouTube channel and look into Dr. Santosh Harrison-based series. That will help you more, right? Crazy loser, great. Not loser, no, change the name. You're amazing. So yes, I'm leaning towards tuberculosis. The one reason why I'm leaning towards tuberculosis and I don't want you to miss this histories, it's India. And India, there's a lung problem which is there for 2-3 weeks. The first and the foremost thing which you have to remember is by default tuberculosis. Right? Let's assume that yes, there was a history of fever, weight loss not much, night sweats not much. Fine, that's all. Okay. Is there any history of pedal edema? Why is this question asked? Anyone? I'm just going restricting my questions to very relevant findings. There are a whole list of histories like past medical history, past surgical history, everything is there. But I'm restricting to very important findings alone here. Why do I need to know the history of pedal edema? Anyone? Like I said, let's go back to the original case history here. It's a 32-year-old, shortness of breath, that is dyspnea or breathlessness, and a right-sided chest discomfort. Most likely it is lung related. There's a possibility it could be heart related also. Very, very unlikely. Possibility is there, right? So one of the commonest thing for my lung is tuberculosis. I kind of asked a question towards that. Second thing is any chance of cardiac involvement, right? I have to ask them because the history is leaning towards breathlessness. The history is leaning towards maybe a possibility of CVS also, right? And let's say that this patient didn't have an history of pedal edema. Okay, great guys. So there's no history of pedal edema. There's a history of fever and a progressive onset of breathlessness. Can anyone tell me what do you guys think of? Let's come to a present diagnosis here. Further examination findings, I'll give you more findings. You might change the diagnosis later, you might not. Can anyone tell me what do you think of? Breathlessness is there, fever is there. That's the only history. No loss of weight, no night sweats. What do you guys think of? It's okay to make mistakes. We are bound to make mistakes. This entire scenario is to make mistakes. What do you guys think? Tracheal lover, Siddhi, what do you guys think? Possibility? Any one possibility? At least can I say, is it infectious, non-infectious, neoplastic, non-neoplastic? Anemia, hypoxia, okay? Can anyone tell me like, we'll broadly categorize them. What do you think? Infectious, non-infectious? Neoplastic, non-neoplastic? That's all. Let's not go into the pinpoint diagnosis. What do you think? Is it infectious or non-infectious? Neoplastic or non-neoplastic? I'll generally lean towards infectious because there's a history of fever. Crazy loser, great. Possibility of pneumonia has to be considered. I'm not denying that at all. And history of fever is there. And there's a breathlessness. 2 weeks, yes, very good likely possibility of a pneumonia, right? So most likely I'm thinking of an infectious, non-neoplastic etiology, right? I'll give you one more history here. One more physical examination finding here. Perfect, right? Trachea is shifted towards the left. See, trachea is always in the midline, right? You know the anatomy. Now I'm saying that this patient trachea shifted towards the left, right? So there are only two possibilities of this. Either there's some lesion in the right side which is pushing the trachea to the left, or there's some lesion in the left side which is pulling the trachea to the left, right? Only two possibilities. Can anyone tell me what could be the reason for trachea deviating to left with this patient? From the right problem or from the left problem? Just comment right or left, that's more than enough. I have a problem of trachea being shifted towards left, and what do you think will be the problem? Right side problem or left side problem? There's an important thing to correlate from the history. That's why I'm asking you. The answer has already been told. What do you guys think? Come on, it's okay to make a mistake. 50% you'll have the right answer, right? I'm just talking about clinical examination, more of clinical medicine. The path part will start slowly. Right side problem. Fakti has gone with right side problem. Singh Saab has gone with right side problem. Perfect, right? Left fibrosis. Crazy loser, why do you want to go to left fibrosis, right? Let's go back to history. That's why it's always a correlation. Here it's clearly mentioned, though might not be accurate, but there is a mention of saying that this patient had a right-sided chest discomfort. So I presume that the pathology is in the right side. I might be wrong, I might be right, but I presume there's a problem in the right side and there's a history of, on examination, the trachea is shifted towards the left, right? Perfect, right? Now, with this history and the examination finding, what all do you think can push the trachea towards the left if there's a problem in the right side lung? Let's take options here. Will fibrosis do it? Yes or no? Just answer them. Will fibrosis of the right side push the trachea to the left? Yes, no. Fibrosis will pull. Answer is no. Can a pleural effusion, which means collection of fluid in the pleural cavity, push the trachea to the left? Yes, no. Possibility is there, right? Because more fluid accumulating here can push the trachea towards the left. Push it, right? Possibility. Pneumothorax. I'm sure you know what is pneumothorax, right? It is air in the pleural cavity. Can air in the pleural cavity push the trachea towards the left? Yes or no? I'm just going to write whatever you guys say yes or no. If you don't say yes or no, I'm not going to write anything, right? So we are kind of ruled out. No fibrosis, possibility. Yes, there is a possibility of pleural effusion, right? There is definitely a possibility of pleural effusion. Yes, there's definitely a possibility of pneumothorax also, right? Because whenever air is also there, I have a possibility of that also to push them, right? Right. Next, can a malignancy or a mass, a big mass in the lung, push the trachea to the left? Yes, no. Very unlikely, but for our argumentative sake, let's keep that also. Okay, a neoplastic process also can push to the left, right? A neoplasm in the right side of the lung can push the trachea to the left. Very, very, very unlikely. Don't answer this in an exam. This is just for our argument's sake. Let's have more differentials, right? Perfect. So these are three possible differentials for me. Now, with the history, we found that it is most likely an infectious disorder, right? Because fever was there. Crazy loser said could be infectious. Someone also said could be pneumonia. Second, it was a very slow, insidious onset of breathlessness, not a sudden onset, right? So if it's infectious etiology and the examination finding, I have not even touched the patient with the stethoscope. I am ruling this out. Unlikely to be neoplasm because 32-year-old person, such a huge cancerous mass or a benign mass is a bit unlikely and might not present with fever and breathlessness, right? Now I have pneumothorax, which is the accumulation of air in the pleural space versus effusion, which is accumulation of fluid in the pleural space, right? Perfect. Now, how many of you watched the series Good Doctor? If you watch the series Good Doctor, learning in medicine is from everywhere, not from the textbooks alone. The introduction scene of Good Doctor is the Sean Murphy, the surgeon, in the airport. There'll be something falling and he'll come back rushing and he'll do some incision and some procedures. Do you remember that? Yes, no, maybe. You must have, right? Perfect. So that is pneumothorax. When air accumulates inside the lung, because lung is completely filled with air, it tears or breaks and the air rushes into the pleural space, right? So the air rushing into the pleural space, do you think it's a sudden onset problem or it will take 2-3 weeks, slowly it will leak? It's a balloon, right? Imagine you have a balloon, you're putting a hole in the balloon. Lung is a balloon. The air will go outside slowly for 2 weeks or suddenly it will go outside. It has to go suddenly, right? So I'm questioning this. Pneumothorax unlikely because most of the case of pneumothorax history will be all of a sudden. A sudden onset of breathlessness, possibility of pneumothorax. Slow onset, very, very unlikely, right? Okay. Now, yes, you are right, Shravan. Now, how do I differentiate this? How do I differentiate? Okay, whatever is pushing here is fluid or air. How many of you have learned about percussion? How many of you have done percussion? You must have done, no? This, you must have done it for sure, right? Sometimes the sound might not even come, right? It's percussion. Percussion, you actually know you don't want patients to do everything. You require time, you require your interest, you can learn everything. After the class, take a water bottle, hit it with water inside, the sound will be different. Hit it in the empty bottle, the sound will be different. Or you must have the water can, the bubble top. Hit it. That is percussion, that is notes. Air will cause more resonant, more sound. Your fluid generally will cause a little bit of dull sound, right? So next thing is, there's a dull percussion note on the right side of chest. Okay, so what do you guys think? Air or fluid? So on hitting, there's a dullness. Air or fluid? What do you guys think? Most likely fluid. Again, I am more leaning towards pleural effusion, right? This is still clinical examination. That's what I said. The correlation or diagnosing a cases first will be clinical examination, then comes the pathology to confirm and investigate, right? Now you tell me, how will you guys confirm this? I told it's an effusion. You also might agree it's an effusion. Some of you might say, it might not be an effusion, it could be a pneumothorax. How do I differentiate? What's the next step? You are the doctor, you are the treating physician, you are in the ward, no one else at all there, you are the only person, you have to confirm it's an effusion. How do you confirm? How do you confirm it's an effusion? Great fact. Can I take an X-ray? Possible? Right, na? Possibly I can take an X-ray easily, right? What is the color of lung in an X-ray? Normal lung ka color? Normal lungs color is black. You must have seen multiple chest X-ray, na? If it is fluid there, it will not be black. If it is pneumothorax, it will be black, right? So just a random chest x-ray, not these patients, right? A random chest x-ray. What I'm having here is, this is the lung. You'll accept that there's a lung because lung will be black in color. This also is a lung. There's the left side, obviously, you can see the cardiac silhouettes, the cardiac shadow. There's a right side. This also is a lung, right? So what's happening here? Can I say that there's a sizable amount of lung which is kind of being taken away from something white in color? Yes, no? It'll be white in color, right? So there's a sizable amount of lung which has been kind of compressed and taken by something white in color. So yes, with the history, with the examination finding, and also with the percussion and everything, and with the x-ray, I'm confirmed that, this is a case of an, right-sided pleural effusion. Is this enough for me? Or do you need something else? Is it enough for me to know how it is pleural effusion, or do you need something else? If it's enough, tell me. If you need something else, you tell me what I require there. It's a simple case of a right-sided pleural effusion, right? A very, very bad writing. Is it enough, or do I need something else? Tell me. Simple case of pleural effusion, nah? So what do we need next? Do I need to know the cause? What caused the pleural effusion? Because I have to treat next, right? It is criteria. What criteria, crazy lover? See, this is a diagnosis. It is not the cause. We can treat the etiology. We cannot treat a diagnosis. I need to know the etiology. I need to know what caused the pleural effusion. It could be simple bacterial pneumonia. It could be a cardiac failure. Cardiac failure also can cause pleural effusion, right? Or it could be fully pus. It's white in color. I don't know if it's pus or fluid. It could be anything. Nah? So I need to know what caused the pleural effusion. For that, then the lab investigation comes. Now it's my part, right? So we'll do the routine investigation. The physician sends me a routine CBC. You might ask first question, and please remember this throughout life. If you cannot explain why you are doing an investigation, don't do an investigation. That's the only criteria or only requirement. If you can say, this is the reason I need the investigation, perfect. But if you cannot say, not at all required. First, they are doing a CBC, complete blood count, right? I'll show you the findings. You're going to tell me the reason for every finding here, right? The patient has mild anemia. Tell, what's the reason? The patient has mild anemia. Tell me why there's an anemia in this patient and what is the implication of anemia in this patient. Every single, as I said, even the tiniest point is important. Look between the lines, read between the lines. That makes you the amazing doctor. There's a mild anemia in this patient. Why is this relevant? So when we go to RBC disorder, we'll read something called an anemia of chronic disease, right? AOCD. AOCD is anemia of chronic disease. Any chronic inflammation in my body will end up in having anemia. That's how it is. Whenever there's more interleukins, it will cause bone marrow suppression. That's how it is. See, imagine a simple way to look at it. I'm having infection. WBC will become more. RBC automatically become less, right? So it will not be that much to affect air gas section. The reason is anemia of chronic disease. How it will impact? See, now I'm going to treat this patient. The patient has less anemia, less nutrition. Can I say the treatment, healing, everything will slightly get delayed? Or the immune response also? For everything, I need good nutrition, no? Without good nutrition, healing will be delayed. So I have to correct this by default, right? Next, it's an elevated leukocyte count. What does this indicate? Anyone? Is this enough? Or I'll add one more finding to this. That's a differential count. Neutrophil of 52, lymphocyte of 44, and eosinophil of 4. What does it mean? Anyone, come on. Whatever comes to your mind. You need not be right. You just need to answer. That's enough for me. Come on, guys, answer. More. Elevated WBC count. Again, can tell my theory. Most likely an infectious cause because WBC count will by default be elevated in infection. Neutrophil of 52, lymphocyte of 44, eosinophil of 4. Can anyone tell me what infection? Infection is right. That is not bit greedy. I want you guys to be bit more right. to this point, what infection? Infection anyone can tell, na? What's the difference between you and anyone who reads the report? I have to tell, or I have to think, probably could be this infection. What infection? I'll divide it superficially: bacterial, viral, tubercular. What do you guys think? Tell me, bacterial or viral or tubercular? See the chronic again. Okay, I gave you categories, no, amongst this: bacterial infection, viral infection, tubercular infection. Possibilities. I will lean towards two, guys. I might lean towards tubercular infection or even viral infection, because just with lymphocyte, I cannot say it has to be tubercular or it has to be viral. So these are the two possibilities with this finding for me, right? So again, I have to correlate everything. Neutrophil is more in bacterial, exactly, crazy loops, right? Guys, I have more lymphocytes here. Normally, lymphocyte in a 32-year-old person is going to be around 25 to 30. If it's 44, definitely more. So I'm going to lean more towards TB or viral infection, right? Next investigation. What do you think must have happened to CRP? CRP is an acute phase reactant, and CRP here will be elevated. Okay. Next question is, I'm going to ask you a question. I want you guys to answer this question. Think well and answer. Can I say in any infection, CRP will be elevated? Yes, no, maybe. It will be elevated, right? So then why do they take? I know for a fact, the patient has fever, body will change, it will be elevated. And what's the point in doing something which I already know? There has to be some other extra information, no? That's what is important. Just to prove my theory and my skill, I don't want a lab test. The reason why I do CRP in any febrile illness, whoever presents febrile illness, right? So CRP tells me not just the elevation, the amount of elevation. CRP is like 4-5 times more than normal. I'll be worried because the infection is very powerful. I might be required to admit the patient. 1.5, 2 times. It's okay, TK. Patient will automatically recover, right? Okay. Great. All the best. Fine. So what is required for me is the amount of elevation, right? So next time when anyone says CRP is elevated, ask them what it is. What is the quantity? What is the amount is being increased, right? Because it's very important for me to know the amount of increase and not just the increase. In some other case, we'll take only about CRP and say, when will you tell, okay, the CRP is severe enough for me to get admitted? At what time? Because infection today, it's there. First day will be high only. If second day, if it drops, okay for me. Second day also high, third day also high is a problem for me, right? There's lots to think to read. Just 20-25 minutes just to talk about CRP. We'll look at it sometime down the road, fine? The amount of CRP is very, very important. Everywhere it will be elevated, right? Okay, CRP is elevated, most likely TB or viral, right? Next is pleural fluid analysis. Then what the physician will do is, they will put a needle here, take pleural fluid and send it to me. So once we have the pleural fluid, these are the findings of this patient's pleural fluid. Straw color to turbid, gross examination. Protein is 4 gram per deciliter. Glucose is 50 milligram per deciliter. Cells are increased, and the cells which are shown here are these. Super, we'll definitely convey to Dr. Santosh. Protein is elevated. Look at these findings. I'm going to ask you a leading question here. Glucose, can I say this is less than the body's glucose level? Obviously. The cells are increased. And can anyone tell me what is this cell? Is it neutrophil? Is it lymphocyte? It is monocyte? It is eosinophil? Can anyone tell me what cell is seen here? This is a pleural fluids microscopic image. What cell is seen here? That's obviously a lymphocyte, right? Now, I said I'll ask you a question. Tell me, this pleural fluid, we just read in the last class in the Nishchay batch, this pleural fluid is an exudate or a transudate? Let's see how many of you can tell the right answer. Exudate or a transudate? What do you think this pleural fluid is? It's an exudate or a transudate? That's a lymphocyte. Perfect. There's a small round blue cell. It's a lymphocyte. I'll obviously call it an Exudate, right? Because it has more cells, it has more proteins, the amount of glucose is reduced. If you remember what we read in the classes, whenever there's an organism in a fluid, it kind of metabolizes, consumes the glucose, so there'll be reduced glucose. Turbidity again due to the cell and the pus formation, right? So proteins are more, that also indicates same, glucose being less, cells being increased. I'm thinking of an exudate, right? So this itself is more than enough for me to say, it's most likely TB infection. Because viral infection will have a different picture. We'll see that soon sometimes down the road, right? It's most likely tuberculosis infection. In a virus, glucose might not be reduced. I'll ask you, you tell me in the next class why glucose might not be reduced in a virus, fine? Now, let's go to a conclusion. The diagnosis is simple. It's a case of a pleural effusion, probably the right side of pleural effusion, most probably etiology being TB. Now, we'll have to complete the discussion. It's a tuberculous pleural effusion, that's all. I have decent enough evidence for me to call it TB. History-wise, chronicity, 2 weeks, slow cough, but I don't have a classical history of night sweats, nor loss of weight, not there. X-ray had a effusion and I have an exudate here. Most likely it's TB. Do I need to confirm or just I can start the treatment for TB? How many of you guys say you have to confirm? How many say you have to start the treatment for TB? I cannot start the treatment, right? Immediately starting treatment is wrong. I always go with evidence-based approach. I have to prove it's TB. Only then I can say, let's go and start the treatment. Does anyone know what could be the final step to do to start the treatment in this patient? Any confirmatory test. I'm going to end with 2 tests here, 2 test name, which we didn't read till now. Whatever we discussed till now has been read somewhere. We're just integrating them, right? I have to confirm. It's very unlikely for me to confirm TB by culture. It's difficult. It might take long days, 2-3 weeks it might take, right? I have to confirm it. There are 2 tests here which I want you to remember. One is called an ADA testing. It's a very, very, very useful test to identify tuberculosis etiology. The other one is PCR. Do a PCR, fine? I'll tell you which is better. ADA is adenosine deaminase, fine? I'll tell you the logic behind ADA. When you go to clinical postings, when you go and sit in the OPD, ADA something is very commonly used to identify TB's effusion or not. Because I need to differentiate bacterial or tubercular. Treatment is very, very different. Bacteria's treatment is different. TB's treatment is different, right? ADA is adenosine deaminase. So if you remember chronic inflammation, the granuloma formation, what we read in TB, can I say there's lots and lots and lots of CD4 cells involved in TB? Yes, right? So whenever there's lots and lots of T helper cells, the purine metabolism increases and that produces ADA. So when ADA is more in any fluid, I tell that in this patient, in this fluid, there's lots and lots of CD4 T helper cells activity. Considering the history, considering the pleural effusion findings, if ADA is elevated, my diagnosis mostly sorted TB. The second thing is TB-PCR. PCR is polymerase chain reaction, right? Now, CB-NAT. CB-NAT is PCR. CB-NAT, anything in CB-NAT is nucleic acid hybridization test, fine? Amplification test. Tell me now, if money is not the concern, what will you do? Will you do a CB-NAT, TB-PCR, or you'll do an ADA testing? Anyone? I don't have a problem with the money. The patient is affordable and also the hospital has good amount of resources. What will you prefer? And also I need why. What will you prefer? And I also need why do you prefer that? Why do you prefer that? I would want you to prefer CB-NAT or TB-PCR for the only reason, not that because PCR is a great test, it's a confirmatory and everything. ADA is also very good. TB-PCR gives 2 values to me. One, it will prove its tuberculosis first. Second, it also can give me the resistance pattern. Because when you go to anti-tubercular treatment, isoniazid, rifampin, there are lots of resistance in TB organism. PCR will help me to diagnose and also give me the drug resistance profile. It's very, very important because if it's a resistant bacteria, I cannot give the standard ATT. I need to know the drug resistance profile also. That's why I would say that TB-PCR is much more superior than an ADA testing. ADA testing will not give me that, right? So it gives both things for me, both the antibiotic resistance, drug resistance, and also the diagnosis, right? That's why we prefer TB-PCR. That's something which is very important for us, right? So this is a simple case. This is how I want you guys to approach. It's sequential approach. Fine. Let's go back from the first. Okay. We had a case, leading questions. There are lots of questions to be asked. I just specified questions to differentiate whether it's infectious, non-infectious, neoplastic, non-neoplastic. It's infectious because of the history of fever. Then, with the help of examination, shift to left and dullness, we almost confirm it's an effusion. X-ray definitely said it's an effusion. We took a routine investigation, gave anemia. We have to always keep in mind, if the hemoglobin is less, I'm going to give ATT. That might even drop the hemoglobin. So I have to be very careful, or correct that first, then go with that. And lymphocytes told me, yes, it's most likely a TB or viral. CRP is elevated, right? And pleural fluid analysis told me it's an X-rays. Microscopy shows a lymphocyte. But I have to confirm. For confirmation, I need an ADA testing or a TB-PCR. I would prefer a TB-PCR for the only reason it can give me a much more concrete report on not just the diagnosis and also the resistance profile. Fine. Okay. That's for today. So this is what I'm going to do. I'm going to take simple normal exam cases which might come in your final year, or you might see in your internship. Initial part, physical examination and other findings, I will not talk in detail. Few informations, few important things. That's not my core. Dr. Santosh will do an amazing job for that. Once it comes to the investigation, I'll pinpoint and tell why exactly each thing is required. Because when you go in a clinics, sit as an intern, I want you to write the right test and also look at the right place to interpret it, right? Not just elevated CRP. What elevation? When elevation? That also is important for us, fine? Okay. Thank you guys. That's all for today. The PDF will be available in the PW Med Telegram group. Just go and have it. And also I have a simple tiny table on the difference between Transudate and Exudate. This also you can have a look at it, fine? Any doubts? Do let me know. If not, let's call it a day.